let's start with the shortness of breath. We'll do the whole thing at once. So shortness of breath, 2 lectures, then small break, then we'll do the neurology after that together. All right. The shortness of breath topic, we need to go through some definitions. So dyspnea means shortness of breath. Tachypnea, I think you guys familiar with these terms, medical terms. Respiratory rate above 18, some reference would say 20 in adults, and different, totally different with the pediatrics. Hyperapnea, to meet the metabolic demands. Someone is really trying to adjust the pH by hyperventilating due to some metabolic related change in the pH, then it's a compensatory mechanism most of the times. Orthopnea is dyspnea while in supine position, and paroxysmal nocturnal dyspnea is a sudden dyspnea at night. What is the difference between the orthopnea and paroxysmal nocturnal dyspnea? Anyone knows? So just to simplify it, when someone say, I have difficulty with breathing when I lay supine, in supine position, that means it's orthopnea. And that goes with most of the times with heart-related issues. But when someone says, I really, every now and then when I sleep, I woke up in the middle of the night and I have feeling that I need to breathe. I feel like I'm gasping, and suddenly, or they would say it's, I don't know what happens, but I feel like I had a nightmare. Like يقول لك يعني كان عنده أو عندها يعني زي الحلم سيء، ولا يحس إن في شيء غريب صحاه من النوم. مرات يكون هذه الشكوى وهو يكون السبب paroxysmal nocturnal dyspnea. When paroxysmal nocturnal dyspnea is actually related to congestive heart failure, but few more things. Obstructive sleep apnea. If someone have like short neck and really obese and have difficulty in snoring at night, sometimes they woke up with this feeling. Or someone have arrhythmias, AFib or VTAC, VFib, they would wake up in the middle of the night with the same concern. So that's why you need to differentiate between those two, because your differential diagnosis is a little bit different. All right, so differential diagnosis, when we talk about shortness of breath, so we have pulmonary, cardiac, and we have metabolic toxins related and neuroendocrinology. So the big bulk is with the pulmonary, cardiac. So let's think about every one of those. So airway obstruction. So yeah, if the airway is actually blocked, then definitely the patient will have difficulty with breathing, right? And usually, if it's upper respiratory, then it will give you stridor, right? Do you guys know what the meaning of stridor? You can use the chat. All right. Okay. Yeah, stridor is like it comes with inspiratory breathing, right? So it's a noise that happens due to some narrowing or obstruction, incomplete obstruction of the upper airways. Okay, good. Then that would definitely, and you would see the patient is really working hard to breathe because of the obstruction, and most of the time they would tell you like they have something blocking their ability to breathe. So respiratory failure, we have different types of respiratory failure, type 1 and type 2, but in general, respiratory failure, it's a term that gives you the feeling that the patient is unable to breathe um, uh, by himself or herself without the support. So that's when you should put this term. Patient is failing, is tiring up, uh, or actually is whatever he does, it's not helping his oxygen saturation. So this is when you say respiratory failure. Anaphylaxis, yeah, so it's allergic reaction, and it's actually involving more than two big organs or systems in the body, and it's causing the body to suffer to the point that it's the time to interfere and fix this allergic reaction, uh, especially with anaphylaxis when it's involving the respiratory system. So they would have wheezing and unable to breathe, and then they probably would be kind of in the middle of suffocation sometimes. So pulmonary embolism. We all know about pulmonary embolism. It's a thrombus goes to the pulmonary through the pulmonary artery, goes to the pulmonary trunk, and goes to the lung. So it could block the pulmonary trunk itself, and that would be a saddle embolism. And that would really, the presentation for that one is different than shortness of breath. Those people will collapse because no blood supply at all is going to the lung, because the thrombus is blocking the pulmonary trunk itself. So nothing going to the right lung, nothing is going to the left lung. So most of the times, these people present with syncope. But when we say shortness of breath, we expect that to be not a saddle embolism, to be probably involving one of the two big pulmonary arteries, and that would lead to difficulty with breathing, because as I said before, with the respiratory failure, whatever the patient does, it's the perfusion. So we have the ventilation and the perfusion. The ventilation is perfectly fine with the pulmonary embolism, but the perfusion of the oxygen through the blood is blocked. Something is actually not helping. The clot is actually obstructing the way to change the oxygen. So the oxygen is arriving to the lung, but unable to meet with the red blood cells. Okay. Tension pneumothorax. So yeah, definitely this is a trauma most of the time, is related diagnosis. And it's, as we all know, you guys did the trauma, I believe, section with Dr. Fahad Bugayan. It's definitely a life-saving condition that the physician can take care of, and it depends on how severe is the tension you interfere. But tension pneumothorax is life-threatening, and when we say tension, that means it's actually affecting the blood supply to the heart, because when you increase the intrathoracic pressure to a certain limit, the pressure would actually kind of squeeze the mediastinum related organs and vessels, that would also lower the venous return to the heart, and that's when you have tension pneumothorax, and it's affecting the blood pressure, affecting the ability to breathe, and all the vital signs related. So pulmonary edema, the edema is actually most of the times is related to heart failure, right? But we have another type of edema. So when we say ARDS, acute respiratory distress syndrome, it's actually, when they put the definition, they say it's actually pulmonary edema, but not cardiogenic. So when you think about the pulmonary edema, don't always think about the heart failure related pulmonary edema. Keep in mind, patient can have ARDS, and that is also a pulmonary edema, but it's not due to heart failure. Okay. Myocardial infarction, we all know that. Cardiac tamponade. So tamponade, the blood is actually in between the pericardium and the heart itself, and it's actually to the point it's blocking the obstructing the aorta, or actually pushing on the ventricles, and the ventricles are not able to fill up with blood. So it's really, really frustrating, and that most of the time is related to something in the heart itself and trauma. Okay. Pericardial effusion. So pericardial effusion is just like the cardiac tamponade, but it's a minimal infusion. Effusion sometimes. And it might be related to pericarditis, as we all know. It's a viral most of the times. And if it's to the point, it's actually getting to a level of severe pericarditis or severe pericardial effusion, then it can lead to tamponade. Arrhythmias, we have different arrhythmias that can cause shortness of breath. As I said, when they say paroxysmal nocturnal dyspnea, they woke up in the middle of the night and they have no idea why they're gasping for air. That might be related to arrhythmia. All right. Then we move to the other side. So we have the toxic, metabolic, and neuroendocrine related. So if people inject or they get exposed to organophosphate or carbon monoxide, then they would have shortness of breath, definitely. This is uncommon, but you should expect that when you have the right circumstances. A farmer or someone like work with um, plants, then you should expect that organophosphate exposure. If you have someone like in a desert and they have like they use like some fire related equipments and like in a closed environment like field, then probably should have a feeling about the carbon monoxide poisoning. Sepsis, yeah, sepsis is really like for any symptoms could be generated by sepsis. So people like when sepsis means like it's multi-organ failure related to infection, and it's to the point that the body is unable to sustain what is happening. So you would expect that person to have any system that is failing, the symptoms related to that system to show up. If it's like acute renal failure due to sepsis, then all the symptoms related to acute renal failure would happen. If you have someone with heart failure related to sepsis, then all the symptoms related to the heart would appear. Okay, just like as if it's whenever it's failing one of the systems, it's all the symptoms would appear for you, and that's why sepsis could generate NA symptoms. DKA, we talked about this. Thyrotoxicosis, yeah, definitely, because thyrotoxicosis would cause arrhythmia most of the time. It's also metabolic because it's increased the metabolic activity in the body, and it's that's probably the reason behind it's causing shortness of breath. Guillain-Barré syndrome, yes, definitely, because it's paralysis and it's ascending paralysis, and it's when it's affecting the diaphragm, then that's when it's actually causing shortness of breath. That's why whenever you have a patient with Guillain-Barré syndrome, you have to consider intubation before they go through respiratory failure, then that's a nightmare because the patient is not able to breathe at that point. So be proactive when you have a patient with Guillain-Barré syndrome to like have a really continuous assessment and early decision about intubation in case you need to. Multiple sclerosis, yeah, definitely multiple sclerosis affects every single organ. It's just like a disease that catch a part, then relief, then get another part of the neurosystem affected, and it's just subhanallah, unbelievable disease like finish. Okay, so let's go to the next slide, assessment. So as we said, we should go through the history, and it's a thorough history. You ask the travel history, trauma, PE, risk factors, the Wills criteria. You guys remember Wills criteria, and Perks criteria or Perks rule. This is a new one we use in the emergency room to help us avoid ordering D-dimer. So if the patient have no role for Perks, then you don't need to order D-dimer. And as we know, D-dimer is highly sensitive. Is really specific. So let's think about the D-dimer. D-dimer would when it's positive, it means your patient might have PE, right? So it's actually sensitive. So it will be sensitive. It will catch any possible PE or any possible blood thrombus in the body that was generated internally. So Wills and Perks will help, but D-dimer is actually the test you do, and it's highly sensitive but not specific. So it's when you have a test that will be positive for any possible case of a disease, then it's a sensitive test. But you need to, and that's why we do screening. When we do screening, we use sensitive tests because we want to catch any possible case. Then we go further and do the confirmatory test, which is a specific test most of the times. Okay. Sick contacts. Yeah, definitely we need to ask about sick contacts, especially now with Corona. And the examination, the appearance of the patient, the pattern of respiration, and the history of cardiac, respiratory, all the other differential related questions should be answered during the history and the physical examination. Investigations, so you do blood work, you do CBC, electrolytes. So every one of your blood work. So I say CBC, then I mean I want to check the hemoglobin. If I have severe anemia, that would cause shortness of breath. I check with white blood cells to see if I have any signs of infection. I also check for the platelets, if I have any internal bleeding, and that's a patient is losing blood and also cause related to anemia, or I have someone with pleural effusion due to hemothorax from trauma, and that also would lower my hemoglobin and also affect my patient. Then I check the electrolytes, sodium, potassium, magnesium, calcium. You check those. The kidney function you need to check too, because as we said, sometimes you have renal failure or like chronic kidney disease, and that's also leading to volume overload. The patient will have edema everywhere, and if the edema is going everywhere, then it would go to the pleural space. and that also can cause shortness of breath. VBG to check the pH of the blood. Cardiac enzymes if you're concerned about heart myocardial infarction. D-dimer if you're concerned about PE. ECG, you want to see the ECG of the patient. Bedside ultrasound to check the heart, the pericardial effusion, and check the lungs if you see any signs of pneumonia or you see pleural effusion. Then you do chest X-ray. Chest X-ray is usually portable if the patient's unstable, and you also will be able to see the lung and the heart and all the related. And when you do the chest X-ray, like few things really catch your attention. If the heart is really big, but you should not judge the heart size with the portable X-ray, because it's like is not reflecting the real size of the heart. But when you do a regular chest X-ray and you have a heart that is really big and it's occupying most of the chest, then definitely heart failure should come to your mind. When I have a patient have shortness of breath, young patient have shortness of breath, I should look for the heart size, because most of the times you would miss this if you assume that the patient is young and probably would have a healthy heart, but it might be the opposite. I had more than one case. I had young in their 20s and they had heart failure. And it was most of the times related to viral myocarditis. So it was viral myocarditis, then developed heart failure secondary to that. Okay, management. In general, you do the monitoring, give oxygen as needed, start the IV access, and make sure that you have patent airway secured and breathing is fine and circulation is okay. Intubate as needed. If you feel like the patient is almost crashing, before you get to that point, you need to be ready to protect the airway of the patient. Treatment, it's according to your assessment. If the patient comes with trauma, so you apply the ATLS guidelines. Patient have an anaphylactic reaction, then you give the treatment for that. If you have a patient with cardiac, possible heart failure, or you have a possible myocardial infarction, you need to treat accordingly. Patient have asthma, COPD, you treat according to your assessment. And finally, infection, you also need to treat accordingly. All right, this is another video. We can go over it at the end if you guys want, but that's it for this lecture. We will go to the next one. All right, let me see. Okay. All right, stop sharing. Okay, here we go. So we'll continue talking about the shortness of breath. We'll talk about asthma and COPD here. So what is asthma? Is the chronic inflammatory airway disease. So it's chronic and it's inflammatory airway disease. It's recurrent. It can lead to recurrent reversible episodes of bronchospasm. So in the past, they thought it was actually just bronchospasm, but they realized it's actually a chronic process and it's affecting the airways by causing inflammatory process in the airways. What would trigger the asthma exacerbation is upper respiratory tract infection most of the times, some allergens and smoking, and in some cases would be related to exercise. Like they go to play and they suddenly have difficulty with breathing, and you think, oh, you should stop running a lot, just relax. then they start coughing, then they feel better, then they go play again. And they say, why this kid is actually having a hard time? You need to work hard. You need to just get exercise, and you can be fit for this at school. But they kind of have no idea that this kid is actually having a acute exacerbation of asthma. So that's why when you have a really good doctor or a really educated team uh, in the school or where you would expect the patients to show up, that's when you have the early intervene and you can treat early and help with controlling the inflammatory process. So classification, this is really like a point that we can use for questions like in the exam, like what class is this, and we can give like different um, like settings or criteria, and you can pick which level or class is the case. So go over it and keep in mind it could be a good part for the exam. So you always check the heart rate, if the forced expiratory volume per the percentage for those, and you also need to think about the other criteria. Okay, so the assessment, so history, you go over the possible triggers, recent infection, as we said, the upper respiratory tract infection is one of the big ones. And if the patient already diagnosed with asthma or had a previous kind of a similar episode, hospitalization, intervention, ICU, stay in the past. These are actually questions you probably will go through if you're suspecting asthma, because you want to think about the severity of the asthma. Is it like severe asthma? I have to admit this patient. He had bad consequences in the past and he was intubated, admitted to the ICU. Was it like a common thing for him, or like just the first episode and have no idea if it's asthma or not? Physical examination, vital signs, yeah, definitely helpful, especially the respiratory rate and the oxygen saturation. Then the signs of the disease, wheezing, and all the other like related uh, muscles use, and the accessory muscles fatiguing probably if the patient has been having this episode for a little bit. Investigation, so you check the chest X-ray, ECG, VBG, and you also need to sometimes, it was part of the assessment in the ER, the forced expiratory volume and the PEFR, but nowadays they're not actually using it as we use in the past. The evidence did not support the decisions was taken in the past according only to the forced expiratory volume. The blood work you do, you probably want to make sure that the patient have no infection, and you check the electrolytes. So I have a note down there. So that's kind of a hint for you. If the patient have symptoms less than 2 per week, a day symptoms, that would be like a mild asthma or a controlled asthma. But if the patient have nocturnal symptoms, any nocturnal symptoms, like at night have woke up at night and coughing a lot or something, that means it's not well controlled. Then you ask about the rescue puffs they use. If they use it more frequently, that's also one of the signs that they're not well controlled. All right, so we go to the management. So you treat the exacerbation. So Atrovent, Ventolin. So what is Atrovent? I want to make sure that you guys, because this is the brand name, Atrovent. So what is the generic name for this? You guys know? So it's ipratropium. So this is ipratropium, okay? And Ventolin is beta agonist, right? So, all right. And steroids, you give prednisolone or prednisone, any steroid that would be good. You give it in high dose. And severe asthma, you need to consider if these three medications you use at the beginning is not helping your patient to control the symptoms, then you move to the next level. So you give magnesium sulfate, IV, and that magnesium sulfate would relax the smooth muscles in the bronchioles. So that's how it actually helps with the symptoms. It's relaxing the smooth muscles. So epinephrine, yeah, definitely epinephrine is the last choice for me, especially if you have like asthma in someone you would be concerned about him to have a heart disease. Epinephrine would make the heart go up to 200 or 250 per minute, like the beats, 200 beats per minute. So this is not your best choice, except if you have to. The patient is about to crash and you wanted to save him from intubation, you can try the epinephrine, but it's the last resort, okay? And same thing, epinephrine would also affect the bronchioles by dilating and relaxing and making the bronchioles more flexible by affecting the smooth muscles and other few things related. Ketamine, IV, yeah, ketamine is recently was actually used with low dose. When you give ketamine high dose, you would actually sedate the patient, and you probably need to intubate the patient. But if you're going to use a really small, tiny dose of ketamine, that would work to help improving the bronchodilate the patient. But you have to keep in mind, whenever you use ketamine, you think about the side effect profile of ketamine. Keep it in mind, because this is a really medication that would be excellent to consider the side effects profile. Ketamine side effects are really crazy, can lead to vocal spasm. So the vocal cords would spasm, and also would increase the secretions in the airways. So the patient might have too much secretions in the airways, and that might have the patient like increase the salivation, and it would think about this patient, you intubate. His vocal cords spasming, a lot of secretions in the way, you don't see good your way to intubate. So if you're gonna think about ketamine, keep that in mind. You should be prepared for such nightmare, and that could happen. Most of the times it's not, but you should keep it in mind, especially when you are working in emergency or ICU setting, because this is really gonna be your reflex in case anything like this happens will be much better if you keep the side effect profile of it. All right, respiratory failure. So yeah, if the patient is failing, then that's the time. Actually, even before that, you should be proactive most of the time to intubate the patient. And that's when you use a high dose of ketamine. So you use the high dose of ketamine to intubate, because ketamine, as we said, is a bronchodilator. So that would help while you're intubating, and you're intubating anyway, so you can go for it. And you use succinylcholine to paralyze the muscles. All right, and move the patient to the ICU. Then we will move to the COPD, chronic obstructive pulmonary disease. So the difference between the the COPD and asthma, that the COPD is not really triggered easily as the asthma, and it's more of a smoking related um, disease. It's the symptoms sometimes similar, but the reason behind is different, and it's more aggressive when we talk about the inflammatory changes and the permanent changes that happens to the lung. Okay, so smoking is the enemy for the COPD. Occupation, dust, chemical exposure, and this is really keep it in mind, because that might be really the cause behind the COPD for your patients. Triggers, same, upper respiratory tract infection, pneumonia, and allergens, smoking sometimes, and congestive heart failure, PE, MI. So usually, honestly, in most of the cases, the trigger would be probably pneumonia. And sometimes it happens like just because the patient is smoking, increasing the smoking and not trying to improve their breathing ability. So they probably need to do some exercise to use the oxygen if they are supposed to use the oxygen at home. But if they're not doing this, they probably would come with an acute exacerbation. So the assessment, so cardinal symptoms, shortness of breath, sputum production, sputum prolonged. So it's actually like infected sputum. So that's one of the questions you would ask. The color of the sputum changed? Is it like what the color was and how it's now? Usually it will be like transparent, and it actually comes to a different color, like green or yellow or whatever. And the duration of symptoms, if the symptoms is getting worse and it's actually acute on top of chronic in all times. So if it's acute on top of his chronic COPD, then that's when you have to interfere in the emergency room. So clinical signs and severity, rapid shallow breathing using accessory muscles, and it's all about like the really worsening shortness of breath presenting to the emergency room. And you need to consider fast and action to control the symptoms. But let me tell you from my experience in the emergency room. So the biggest concern for me in the emergency room when I have elderly, so the COPD is most of the time, 90% of the time is actually above 50-year-old or like 45, let's say 45. And they would have most of the times diabetes, hypertension, or all the spiel for the chronic diseases we have. And they would come to the emergency room with acute shortness of breath. What should come to your mind? You should think about heart failure. You should think about ischemic heart disease. You should think about PE, pulmonary embolism. These people are really at high risk for all of that. So when you have them come, you would not see it clearly, this patient have COPD exacerbation. No, you would think about million different causes of this shortness of breath. That's why the key to differentiate between the cardiac cause of shortness of breath and pulmonary cause is a really big factor for success treating the patient in the emergency room. It could be combined, yes, could have both, like he is heart failure patient, and on top of that, things getting worse regarding the COPD and the heart failure. But definitely one of them is leading this worsening. So you need to control that first. So if you listen to the lungs of the patient, you would hear wheezing. if it's actually COPD most of the times. Let's say most of the times, because sometimes actually they are not even having any air going through most of the lungs, so we would not hear the wheezing. But let's say most of the times they would have wheezing in the lung exam. But for the heart failure patient, you would hear crepitation. So it's different. So when you hear crepitation and you don't hear any wheezing, then probably this is acute exacerbation of heart failure. And it may be combined with a mild like exacerbation of COPD, but it's probably heart failure related. But when it's actually you hear wheezing and really not much of crepitation, then that's when you say it's probably a COPD exacerbation with maybe a minimal factor of heart failure. Okay. So you order the workup according to your judgment from the physical examination and the history. Then you also order the radiology related tests. So the management, you give oxygen and you wanted the oxygen around 88% in the monitor, but PO2 is actually the target between 60 to 65 minimum. You can go up above that, but that's your target as a minimum. I would also go with the oxygen and the monitor up to 90, 91, 92 is okay, but 88 is the minimum also you would accept. You give bronchodilators as you do with asthma. You give steroids as you do with asthma. But here, the evidence did not support one on top of each other. So with asthma, beta agonist is actually superior to ipratropium. But here, no evidence that one is better than the other. So all the bronchodilators actually is okay, even though it's not the best. That's why you give both. You give albuterol and you give the ipratropium together. In the asthma, you give the albuterol first. So then you give steroids. Steroids helps, and you also consider giving. And by the way, steroids oral and IV would give the same effect, but in the emergency room, most of the times we give a high dose of IV if we have IV access. Especially because these people will have difficulty of breathing and shortness of breath that you might need to intubate. So you better have IV access when you assist those patients. So management, you also give antibiotic. Antibiotic, you need to cover the possible bugs that would cause the pneumonia. As we said, pneumonia is the biggest trigger for the COPD exacerbation. So you can give amoxicillin, you can also give doxycycline. And if you think the patient probably have some complicated exacerbation, so you should consider augmentin and ciprofloxacin or levofloxacin. I would do levofloxacin because the levofloxacin would cover more organism than the cipro, especially for Pseudomonas. Okay, ventilation. You give like oxygen through the nasal cannula, but you also can use the BiPAP to improve the oxygenation. To improve this ventilation. You need to improve the ventilation in these cases because you're concerned about the carbon dioxide level in the blood. These people have obstructive lung disease, so they would have difficulty washing out the CO2, right? So that's why you're concerned that they might develop respiratory acidosis, right? Because the CO2 is acidic. So if they're retaining the CO2, then they're actually having respiratory acidosis. And you need to compensate that by improving the ventilation, and you sometimes have to compensate it with other options. And consider intubation if the patient is having difficulty to return or improve from the current situation of acute exacerbation. All right, thank you. You guys have any questions before we go to the break? Questions? All right, so we'll meet after 10 minutes.